Thank you. I want to make sure I'm set up with my self-monitoring of my time. It is such an honor to be on this platform and speak next to some people who I've admired throughout the years. So I'll yield some of the description of who I am to just express gratitude for this panel and everyone who's on it. Um, I'm going to talk about a publication that Diana Padilla Medina and I published recently in Trauma, Violence, and Abuse. And we came to the idea of investing in this study because we both had and have a commitment to examining natural settings that we can reach people, particularly men who act abusively, and reach them in ways to get them help and intervention, ways that are non-carceral. So we've thought about certainly community connected organizations. I studied and am continuing to evaluate a completely voluntary program in Chicago called the Men's Group. And I have some publications in that area, but we wanted to find ways to add to the literature and conversation about expanding non-carceral intervention. And so one way that we came up with to do that is like, okay, what are natural settings that people disclose like sensitive or private information related to their romantic or interpersonal relationships. So I do a lot of work with churches. Certainly people disclose to their people in their parish or their church, clergy across religious traditions. So that's one area that I examine. But not everybody's in church or it's part of a faith community. And so to expand that, we thought, what else? And came to the conclusion that healthcare settings would be a natural place where many people would have access to, and which they might be willing to engage in with conversations with their healthcare provider. So I also focus heavily on making sure that the measurement tools that we have in this field are applicable and useful across racial and ethnic diversity. So I focus particularly on examining interventions and services that are particularly beneficial to Black and Latino men. So we needed to examine if there were existing tools, measurement tools that had been evaluated for their psychometric soundness, so that before we went off and suggested for practitioners and physicians to ask these questions, that there was some meat behind or some depth behind the tools that we were suggesting to be used. So we did a review of existing work and a number of studies. In our review, I was introduced to Dr. Singh's work, and a number of studies have found that patients disclose their IPV perpetration, as he mentioned, while receiving health services. Research is also, has also demonstrated that men and women would feel comfortable disclosing IPV perpetration or victimization if they're questioned by a healthcare provider. However, in spite of this willingness to report, as I mentioned, the literature indicates that medical professionals struggle with maybe how to identify or how to respond when presented with such disclosures. And so the process of screening for IPV perpetration in the healthcare system thus far has been done kind of haphazardly without any sort of systemic or systematic implementation, without agreed upon guidelines on what specific questions that providers should ask, et cetera. So we sought to investigate what the state of the empirical literature was in terms of reliable and valid screening tools for assessing IPV perpetration or risk of perpetration. And when we conceptualized this, we were thinking about emergency rooms, community care clinics, and primary care providers, because healthcare providers have a powerful voice in getting people to uptake treatment that is necessary to improve their own health. And while there's mixed evidence regarding how patient or care provider trust is established, several studies have shown that the level of trust that patients have regarding their physicians and other healthcare providers directly influence their decisions to engage in or adhere to recommended treatment. Ultimately, the vast majority of patients trust their healthcare providers in some way to act in their best interest, thus justifying a provider involvement, amplifying provider involvement efforts to identify people who need help to stop abusive or violent behaviors in a non-carceral sort of way. So just to briefly overview, the method we did was a scoping review, and the inclusion criteria for tools that we evaluated were that they be brief or rapid. We conceptualized that as 10 items or less. And although we scoured the literature for a guide on that, and I'm curious to hear Dr. Singh's thoughts about that, but there wasn't really an established, like, for a measurement tool to be practically implemented in a fast-moving healthcare setting, how many items it needs to be. So we just conceptualized it as 10 or less. And the study needed to be published in a peer-reviewed journal and have reports on their psychometric properties. Initially, we examined the potential of around 1,400 potential studies and drilled down to 5 eligible articles. Having measures that are psychometrically sound is really important, but the brevity and comprehensiveness of the tool are also really key elements for consideration. Here is just kind of a very brief overview of comparing some of the properties of the tools that we examined. And again, this is available in the publication that I've linked to the materials for this session, so you can look at them at length. But 3 of the 5 studies were administered in English only, and 1 was administered in Dutch only. 1 study was administered in 2 languages, Spanish and English. However, the overwhelming majority of the sample elected to take the test in English, meaning that there was not enough variation to conduct invariance testing across languages. Also, there was no invariance testing done across age groups to determine whether people in different generations or in different racial or ethnic groups interpret the questions similarly or differently. And that's important because linguistically speaking, the sentence structure may be understood similarly or differently across populations. Overall, while there were variations between studies, the measures all demonstrated acceptable psychometric properties. And I'm going to fast forward a bit here. Again, this is available in the publication and also included in this slideshow that will be posted as well. Here's some samples of the type of questions that are included on some of these tools. So for example, Portnoy et al. Asked, in the past 6 months, how often have you done the following to a past or current intimate partner? And then they go through a list of items such as physically hurt him or her or them, insult or talk down to them, threaten with harm, etc. You can look at some of the other ones. For a variety of reasons, the two instruments that we found to have substantial benefit and properties that were important to practical implication was the modified extended modified EHITS, which the EHITS is an existing tool that examines victimization, and Portnoy and her colleagues extended that to examine perpetration. And the JIPV, the Jelinek Inventory for Assessing Partner Violence. One thing, I'll back up here. As we're looking at this, one thing that's important consideration is the differences in language of how these tools are introduced. So you can see in terms of the time frame that they ask, each one has a different sort of preface comment of either how have you ever, or in the past 6 months, or in the past year. So that's something you'd want to take in consideration if implementing it into your practice in terms of what would be appropriate for the population you're serving. I want to touch briefly on the purpose of screening in terms of how we've thought about it. We did not do this in order to identify another way to sort of catch people and report them to police or carceral authorities. And so when we think about this in terms of purpose, we're thinking about connecting people to relevant interventions or resources with the overarching goal of reducing harm and improving patient health and also partner health. Some things to think about in terms of the future is, given the complexity of the relationship experiences and how patients report the nuances of their behavior, particularly dissecting the myth of this binary victim and perpetrator, it might be beneficial for more studies to examine the psychometric properties of tools that are multidimensional. And in that, I mean tools that capture both victimization and perpetration. That was one of the reasons we looked at the JIPV, or the modified EHITS, as a potential brief tools that could be implemented, because they have already the evidence to support those questions being asked in a sort of survivor-based and perpetration-based. In our review, the JIPV was also one of the only tools that contained that capability in terms of implementing all 4 items in a healthcare setting. Another important question to ask is, does screening and referral resolve other barriers to getting treatment and directly translate to increased voluntary enrollment in treatment for IPV perpetration? Again, we want to expand beyond the carceral or criminal justice mechanism of people winding up in treatment, and expand options in terms of how to get people to voluntarily enroll. But the question remains, does screening actually do that in terms of building that bridge? And another, a couple of more points I'd like to make is that in terms of challenges, there is inconclusive evidence about the efficacy of, quote, battering intervention programs. And so there's wide variability in terms of if you know when you're referring to someone who's local, if that's a program that's actually making change in people's lives. And I'm really inspired by the trauma-informed and oppression-sensitive programs. I'm just excited about the expansion of that, because that, again, is an area that is deserving of more attention. Finally, an area to think about is sort of a structural barrier to accessing treatment for IPV perpetration, maybe the cost involved, thereby impeding initial participation in treatment and treatment adherence. For example, insurance might not cover the expense of behavioral health interventions like this, and there's currently no diagnosis for IPV perpetration, but that is something that should be of considerable thought, especially when we think about, again, community-based responses in terms of providing resources for helping people to engage in healthy behaviors within their relationships.
Thank you so much, Maxine. This is a wonderful presentation. We are a bit over time, so I'm so happy the presenters have been answering their questions in the chat. This is amazing work, very exciting. And so we now need to end this. I want to thank Kim, our interpreter, and the Spanish, Margot, our Spanish interpreter as well. And next is the 20-minute mentoring coming up. I hope you signed up for that. And at 4 o'clock Pacific time, we have performance by the artist with Keith Maskell. So hope to see you all then. And thank you so much. Have a great evening. Bye-bye now. Bye-bye. Bye-bye, everybody. Take care. Bye-bye.